everyone, I'm Easy Peasy Medic here. Today in my first video, I would like to talk to you all about Kawasaki disease. So I have already summarized everything about Kawasaki disease into different points for your better understanding. So first of all, I would like to move on to the definition of Kawasaki disease. Kawasaki disease is also known as mucocutaneous lymph node syndrome. It is an acute systemic febrile syndrome characterized by generalized vasculitis involving small to medium-sized arteries. Next, I'll be moving on to epidemiology. It mainly affects children of 6 months to 4 years old with a peak at the end of the first year. The disease is more common in children of Japanese and to a lesser extent Afro-Caribbean ethnicity than in Caucasians. Young infants tend to be more severely affected than elder children and more likely to have incomplete cases, in which not all the cardinal features are present. Although the specific cause is unknown, it is likely to be the result of immune hyperactivity to a variety of triggers in a genetically susceptible host. Next, I'll be moving on to diagnostic criteria of Kawasaki disease. One of the most common diagnostic criteria is fever that is higher than 38.5 degrees Celsius for at least 5 days, and this fever must be fulfilled with at least 4 out of 5 of the following criteria, such as bilateral non-purulent conjunctivitis, polymorphous non-vesicular rash, cervical lymph adenopathy, strawberry tongue and dry cracked lips, and erythema, pumps and sore with swelling. Moreover, Kawasaki disease is usually associated with other clinical feature or typical feature involving CNS involvement such as irritability, altered mental state, and aseptic meningitis, as well as erythema or induration at BCG site, perianal excoriation, transient arthritis, diarrhea, vomiting, abdominal pain, hepatosplenomegaly, high drops of gallbladder, sterile pyuria, pneumonitis, uveitis, and otitis. The most important and common complication is coronary artery aneurysm, usually within 2 weeks of illness affecting up to 25% of untreated children. However, Kawasaki disease is usually asymptomatic. It may manifest as myocardial infarction, myocarditis, pericarditis, endocarditis, heart failure, erythema, cardiac tamponade, and others like peripheral artery aneurysm and gangrene. Move on to the risk factors of children with Kawasaki disease getting complications like coronary artery aneurysm that are prolonged fever, prolonged elevation of inflammatory markers such as C-reactive protein and erythrocyte sedimentation rate in children aged younger than 1 year old and older than 6 years old, usually in male gender and children with atypical Kawasaki disease. There is no diagnostic test. Instead, the diagnosis of classical Kawasaki disease is made based on clinical features as per mentioned. Therefore, investigation below should be done. In full blood count, there are anemia, leukocytosis, and thrombocytosis. There are high inflammatory markers such as C-reactive protein and erythrocyte sedimentation rate. In liver function tests, there are low albumin and elevated alanine aminotransaminase. In blood culture, it is to assess any infection or inflammation due to high fever. And just for your information, before doing any CSS lumbar puncture, coagulation profile must be done to assess any coagulation impairment such as disseminated intravascular coagulation to prevent any contraindication in the CSF lumbar puncture. In chest X-ray, there may be findings such as reticular granular pattern, peribronchial coughing, air trapping, atelectasis, and pleural effusion. In electrocardiogram, there may be sinus tachycardia, An echocardiogram is performed at diagnosis which may show coronary artery aneurysm formation, which can be more than 8 mm in diameter, pericardial effusion, poor myocardial contractility, and valve regurgitation. If the coronary arteries are abnormal, coronary angiography or MRI will be required. Next, I'll be moving on to the treatment of Kawasaki disease, and that are intravenous immunoglobulin, IVIG, oral aspirin, corticosteroid, infliximab, cyclosporin, and immunization. Prompt treatment with intravenous immunoglobulin given within the first 10 days has been shown to lower the risk of coronary artery aneurysm. Aspirin is used to reduce the risk of thrombosis. It is given at a high anti-inflammatory dose until the fever subsides and the inflammatory markers returns to normal, and continue at a low antiplatelet dose until echocardiography reveals the presence or absence of aneurysm. When the platelet count is very high, antiplatelet aggregation agent may also be used to reduce the risk of coronary thrombosis. Vaccination like live attenuated virus vaccine should be delayed for at least 11 months, as the use of intravenous immunoglobulins may impair the efficacy of this kind of vaccine. Thank you for watching and lending me your ears. Please like and share my videos as well as subscribe to my channel. I will see you in my next videos. Bye!